All right, here we go. Back on EKG, Chapter 8, Introducing the Atrial Rhythms. Let's see what we're going to talk about. We're going to talk about the origin of atrial rhythms. You know we're going to talk about the electrical conduction system of the heart. Then we'll talk about wandering atrial pacemaker, PACs, atrial flutter, and then atrial fib, SVT, WPW, or Wolff-Parkinson-White syndrome, and then we'll talk about the clinical significance of these different rhythms that we're talking about, these atrial rhythms. So when we talk about atrial rhythms, they're classified based on where the electrical impulse begins. So whether that's from the SA node or if it comes from somewhere else in the heart. Now if the SA node fails to generate an impulse, then the atrial tissues or the internodal pathways might step in to initiate the impulse. So this is where things can get a little interesting, because now the electrical activity is coming from places other than the usual pacemaker, which can lead to rhythms that are different from the typical sinus rhythm. So we'll see how the heart tries to compensate when the SA node isn't calling the shots here. Now, this is what we're going to talk about, atrial dysrhythmias. So they originate in the atria rather than the SA node. So while they're generally not considered life-threatening or lethal, they still require continuous assessment. So just because these rhythms are not immediately dangerous doesn't mean they should be ignored. So ongoing monitoring is going to be really important to make sure the patient's condition doesn't worsen or lead to more serious complications. So we know that electrical impulse, it starts in the SA node, travels to the atria via the internodal pathways. These pathways help distribute the impulse across the atria, ensuring that both atria contract and sync, which is essential for proper blood flow into the ventricles. So the heart's still relying on the usual conduction system just as it would in a regular sinus rhythm. Now this is a typical process when the impulse originates from the SA node. So once that impulse reaches the AV node, there's a brief pause. Now this pause is really important because it allows the ventricles time to fill with blood before they contract. Now after that pause, the impulse travels down the bundle of His and then splits into the right and left bundle branches. And then from the right and left bundle branches, the electrical impulse travels to the Purkinje fibers, which spread that signal throughout the ventricular musculature. So that ensures that the ventricles contract efficiently, pushing blood to the lungs and the rest of the body. And those Purkinje fibers are crucial because they ensure the ventricles are activated in a coordinated way, allowing for effective pumping and blood flow as well. Something you've already seen if you've watched any of the others. So we know the firing rates and the different portions where they're coming from. And then we see the pacemaker sites here. So let's talk about wandering atrial pacemaker. So these rhythms occur when that pacemaker sites, it shifts or it wanders, that's in the name, from the SA node to other pacemaker sites in the atria or the internodal pathways or even the AV node. So even though the impulse may start elsewhere in the heart, the SA node remains the basic pacemaker, meaning it's still the primary source of electrical impulses in the heart, even if other sites take over temporarily. So this wandering pacemaker activity is what leads to variations in the rhythm, but the heart's still trying to maintain a coordinated beat. So in these rhythms, it's important to remember we've got to observe at least 3 different P waves. That's because as the pacemaker sites wander, the size and the shape or the morphology of the P waves will vary depending on where the impulse is originating from within the heart. So the P waves can look different in several ways. They may appear upright or inverted, or in some cases you might even see absent waveforms. This variation happens because the electrical impulses are coming from different areas of the atria or even the AV node. So each wave is shaped differently as it travels through the heart's conduction system. So when there's an absence of the P wave, it could mean the P wave is actually just buried within the QRS, and that can happen when the impulse starts somewhere other than the SA node, and the P wave gets hidden in the QRS, making it much harder to see. Now the PR interval, it may be regular or it could vary depending on where the impulse originates. If the pacemaker site shifts, the timing of that PR interval can change because the impulse takes a different route through the heart. So importantly, these rhythms often produce no symptoms, typically only noticed when reviewing the EKG. That's why it's crucial to closely observe the rhythm strip even if the patient doesn't feel any different. So when we look at our table here, we see the rate still usually 60 to 100. Now, however, the rhythm can be slightly irregular, and the big thing we see is when we look at the P wave, you see a change in size, shape, and location from beat to beat, and then there can be a variation within the PR interval as well. So when we look at this one, we see some different P wave shapes. This one's almost, you can see these are almost going back to that isoelectric line. However, they're still there, so we know that pacemaker side is just shifting. Now, multifocal atrial tachycardia, or just MAT. So this rhythm is a variant of wandering atrial pacemaker, and it's called multifocal atrial tachycardia. It occurs when the heart rate reaches 100 beats per minute or greater. So the key difference between MAT and wandering atrial pacemaker is a faster heart rate. Now, because of this varying P waves and the rapid rate, MAT can sometimes be confused with atrial fib. However, in MAT, you'll still see multiple P waves of varying shapes, whereas in atrial fib, you'll see no distinct P wave at all. So this is commonly observed in patients with advanced COPD, maybe some digoxin toxicity, and some electrolyte imbalances. So, it's important to identify this rhythm because while it may not be life-threatening, it can indicate some underlying conditions that need some attention. So when we look at this, we look at our rate, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We got a rate around to 120. Rhythm looks really pretty irregular because we can see just the differences here. We see that happening throughout. Now, when we look at our P waves, they are present. They are variable, though, and we see that they're different shaped. Their shapes are variable and kind of all over the place. Our PR interval is variable as well. However, our QS is quite normal. So our rhythm is multifocal atrial tachycardia. Now let's talk about PACs. So premature beat occurs when a single electrical impulse originates outside the SA node. So it can come from the atria, the AV junction, or even the ventricles, just talking about premature beats as a whole. So this impulse causes an early beat, which is why it's referred to as a premature beat. So this premature beat comes earlier than the next expected regular beat, and that's causing the rhythm to temporarily become irregular. Now, that complex associated with the premature beat might look different from the usual complexes because it originates from a different part of the heart. So these early beats are often harmless, but they should be observed, especially if they become frequent or are associated with other symptoms. So when we talk about premature beats, the term contraction is often used, but it's important to remember that we're really just referring to electrical activity in the heart. So the term complex is more accurate because it represents the electrical impulse traveling to the heart, but it doesn't necessarily reflect the mechanical activity. So what we're saying is, the actual muscle contraction of the heart. So when discussing premature beats or any arrhythmias, better to use the term complex rather than contraction. But the complex shows the electrical activity that triggers the heart to beat, but it doesn't always translate directly to the heart muscle contracting or pumping blood in that moment. So after a PAC, you'll often see a non-compensatory pause. So this means the heart doesn't fully reset after the early beat, unlike with some other premature beats where the pause is longer and more compensatory. So the PAC itself doesn't significantly alter the overall rhythm of the heart. The underlying rhythm, the one the heart was following before the PAC, will continue once the non-compensatory pause ends. However, during that brief pause, the heart is interrupted, but then it picks right back up with the normal rhythm, just as it was before the PAC occurred. So this cycle continues with each PAC, causing a brief interruption until the next one comes along. Now, I just put this together because there's questions many times about non-compensatory versus compensatory. So this is not in your text. But when we say non-compensatory, what is that? That non-compensatory pause happens after an early or extra beat, but the heart doesn't really catch up. and fix the rhythm. So the pause is shorter, so the next beat is a bit off from that normal timing. Now after the early beat, the heart pauses for a shorter time, but it doesn't make up for that missed beat. So the next beat happens too soon, making the rhythm a little off, indicates that sinus node was reset. And that's a big important part, that the sinus node was reset by that early beat. So what we're saying is, when you look down here, you can see this was an early beat here. And one of the things that we'll talk about with PACs is typically you'll see a different morphology of your P wave here on this early beat, and that'll let you know it's a PAC. However, you see we had this early beat and it goes right back to its normal rhythm until the next PAC. But when we talk about a compensatory pause, which we're kind of jumping a little ahead, I just want you to know the difference, because we'll talk about compensatory pauses when we look at PVCs. A compensatory pause happens after the heart beats too early, like if the heart skips a beat or if it has an extra one, so the heart then takes a break or a pause to catch up so the rhythm stays regular. Now after that early beat, the heart takes a break long enough to make sure the next beat comes at the right time. So it's like the heart waits for its turn just to keep going as it normally would. So what we're saying is, if the P to P interval surrounding an ectopic beat, and that ectopic beat is when a beat comes from somewhere else, so we're talking about this premature beat, is less than 2 normal P to P intervals, we call that a non-compensatory pause. And then if the P to P interval surrounding an ectopic beat is equal to 2 normal P to P intervals, we call that a compensatory pause. So we notice down here, and it's got a nice little graph here, we have 1 R to R interval, and we notice this rhythm is just continues on with the way it originated. So we see here we have that extra beat, as well as you notice the morphology of this is wide and irregular, versus when we looked at the PAC, it was nice and tight. And it just, so it has a longer pause, and then it just picks up to where it was going. So the main difference is whether or not the heart kind of just fixes its rhythm after the early beat or not. And if that completely confuses you, then I apologize. However, let's talk about PACs in our table here. So the rate's usually normal, the rhythm usually regular, except for that PAC. And then the P wave differs in shape, size, and location. And then we see that the length of the PR interval is variable depending on the pacemaker site. That's a PAC. So when we look down here, we see we're just trucking right along, and all of a sudden, pop, we get an early beat, and then it resets its rhythm back to normal, which is the same amount of distance here and here. And that's a PAC. So that's going to be we see P waves. So even though the QRS looks a little bit awkward, that's still a sinus rhythm. So that's a sinus rhythm with a PAC. Make sure you always look at the underlying rhythm. So it's not just a PAC, but it's a sinus rhythm with PACs. Now let's talk about some sequential patterns of PACs. So when you see 2 sequential PACs, it means the PACs are occurring in pairs. And this is referred to as atrial bigeminy. So in bigeminy, you'll have a PAC every other beat. So the pattern alternates between normal beat and a PAC. Now if the PACs happen every 3rd beat, that's called atrial trigeminy. In trigeminy, you'll see the regular rhythm for 2 beats followed by a PAC, then it repeats. So these patterns help in identifying the rhythm and then just understanding how the PACs are affecting the overall heart rate and rhythm. Although these variations might not be immediately life-threatening, it's still important to monitor how often the PACs occur and whether they cause symptoms. Now, PACs can look very similar to normal complexes of the underlying rhythm. The key difference is that they occur earlier than expected, but the P wave of the PAC often resembles the normal P wave of the rhythm, though it may look slightly different, and that's because of the origin of that beat. Now, because they closely resemble the normal beats, it can be easy to miss them unless you're paying attention to the timing and any brief pauses that might follow. So while the PACs might not drastically change the overall rhythm, they can still have an impact on how the heart beats, and they are important to track. So they can be triggered, these PACs can be triggered by a variety of factors, including the use of stimulants like caffeine or alcohol, of course hypoxia, Increased sympathetic tone, so talking about anxiety or times of stress, electrolyte imbalances, digitalis toxicity can affect that too. Now, when a premature beat like a PAC occurs more than 6 times per minute, it's considered frequent. So while a few PACs here and there might not be a huge concern, when they've become frequent, it's important to look for that underlying cause and then assess the patient's condition, as frequent PACs can sometimes lead to a more serious rhythm issue. All right, let's move on to re-entry dysrhythmias. So when we talk about re-entry dysrhythmias, we're talking about that reactivation of myocardial tissue. So for what it is, it reactivates for a second or subsequent time of the same impulse. So rather than one impulse going through and creating one beat, we're talking about that it creates this loop and it continues to stimulate the heart. So that's talking about re-entry. So it occurs when an electrical impulse loops back on itself and it stimulates the heart tissue more than once. So that can happen if the impulse gets caught in a loop, reactivating the myocardial tissue again and again. So a short circuit in the electrical conduction system is one way that re-entry develops. Now this occurs when that electrical impulse is delayed or blocked along its usual pathway, and it's creating a situation where the impulse can loop back and stimulate the heart tissue multiple times, and that of course leads to abnormal rhythms. So this can cause arrhythmias, and depending on where and how it happens, could lead to more serious issues with the heart's ability to pump blood effectively. Now, when there's a delay in the normal electrical conduction, it allows that impulse to travel in only one direction. So this happens because the pathway the impulse usually takes is blocked or delayed, preventing it from traveling in its normal route. So as a result, that impulse starts to move in a cycle throughout the heart tissue, and it repeatedly reactivating it. So this creates a situation where that heart goes through a series of rapid depolarization, or just these fast electrical impulses. Now these fast depolarizations can lead to rapid abnormal rhythms, which is a hallmark of certain arrhythmias such as ventricular tachycardia or atrial flutter. Now the heart can get caught in this reentrant cycle, and unless the impulse is interrupted, it may continue firing off fast, causing a rapid and potentially dangerous heart rhythm. So when we see here, we look at this, we see, let's just take a quick gander. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. We have a heart rate of about 180. The rhythm looks quite regular. P waves, not going to probably, that's probably could potentially be a P wave. However, what typically happens is this heart rate is going so fast that it's hard to see the P wave because it almost just gets smushed in there. So the PR interval, if we are saying that is the PR interval, we see that we're probably talking, very, very short amount of time. So when we talk about SVT, it's very common to not see your P wave. So the causes of these reentry dysrhythmias typically stem from conduction delays or blocks, as we've talked about, in the heart's electrical system. So some common condition and factors lead to these issues. They include hyperkalemia, so myocardial ischemia, where the lack of blood flow to the heart tissue, it causes that damage that can block or delay electrical signals. Certain antidysrhythmic meds, so they can affect the electrical properties of the heart and even potentially set up a re-entry circuit. So some specific rhythms that arise from re-entry include atrial flutter, atrial fib, PSVT or SVT. So we're going to talk about these, but these rhythms all involve some form of re-entry in the electrical conduction system, and this understanding the causes is essential for both diagnosis and treatment. All right, so atrial flutter. You'll see regular atrial activity within a distinctive picket fence or sawtooth pattern, and this is more of a better example, but you can see that it has that picket fence or sawtooth pattern example that comes from that rapid repetitive firing of a single irritable site in the atria, and it's generating multiple electrical impulses at a fast rate, often between around 250 to 350. Now, because these impulses are firing so quickly, the normal P wave doesn't have a chance to form, as we usually see in sinus rhythm. So instead you get that sawtooth appearance of the atrial activity, and that's a hallmark of atrial flutter. So the electrical impulses, they travel through the atria at a high speed, but not all of them are able to get through the AV node. Remember, that was that gatekeeper, so it's not allowing all of those to go through to the ventricles, because the AV node blocks some of the impulses to prevent the heart rate from getting too fast. So that results in those characteristic flutter waves on the EKG instead of those normal P waves. Now in atrial flutter, instead of the normal P waves, we'll see flutter waves, also known as F waves. These waves have a sawtooth or picket fence pattern, and these F waves are the result of rapid repetitive impulses being sent out by that irritable site in the atria. Now we mentioned it, but that AV node, it acts as a gatekeeper to the ventricles, so it decides how many of the fast atrial impulses will get through to the ventricles. Because the AV node can only conduct a limited number of impulses at a time, the ventricular response, it depends on how many impulses the AV node allows through. So this is often seen as a slower ventricular rate, so compared to the rapid atrial rate anyways, and it can vary depending on how much the AV node is able to conduct. For example, if the AV node lets through every other impulse, you'd see a 2-to-1 conduction ratio. So 2 F waves or 2 flutter waves for every 1 ventricular beat. So that conduction ratio that we're talking about with atrial flutter, it refers to how many atrial impulses get through the AV node to the ventricles. Now that ratio can vary depending on how much the AV node allows the fast and atrial impulses to pass through. So for example, I mentioned it, but a 2-to-1 conduction ratio means that for every 2 atrial contraction or flutter waves, you'll get 1 ventricular contraction. And that would result in a ventricular rate that's half of the atrial rate. So a 4-to-1 conduction ratio means that every 4 atrial contractions, you'll only get 1 ventricular contraction. So in this case, the ventricular rate would be much slower than the atrial rate. So for instance, if the atrial rate is 300, which is typical for atrial flutter, the ventricular rate would only be around 75 if you have a 4-to-1 conduction ratio. And that occurs because only 1 out of every 4 atrial impulses is conducted to the ventricles. So in atrial flutter, the ventricular response can vary depending on how the AV node handles the atrial impulses. So we can see atrial flutter with a slow ventricular response, or you might sometimes hear it or see it referred to as an SVR, slow ventricular response. In this case, the ventricular rate is less than 60 beats a minute. So that typically happens when the AV node is only allowing a few of those rapid atrial impulses to pass through to the ventricles, creating a slower rate. Now, atrial flutter with a rapid ventricular response, or RVR, here the ventricular rate is 100 to 150. This occurs when that AV node is allowing more of those atrial impulses to be conducted through to the ventricles, and that results in a faster ventricular rate. So it can be more concerning because the heart rate is pumping rapidly, and if the ventricles are beating too fast, it may impact the heart's ability to effectively pump blood. So atrial flutter, when we look at our table again, we see what is the rate. Typically atrial 250 to 300, ventricular can be variable. Rhythm is regular. The big piece though is we see that the P wave, when we look for P waves, normal P waves are absent and they're replaced by flutter waves, or those sawtooth waves or picket fence. So here's a really good example of what we're talking about. So when we look at our top one, when we look at our rate, we've got 1, 2, 3, 4, 5, 6, 7, 8. Looks pretty regular. Got 1, 2, 3, 4 boxes. 1, 2, 3, 4 boxes. March that out all the way across. Now, P waves, we don't see P waves. We see that they're replaced by those flutter waves. So there's no PR interval. And then QRS looks quite normal. So this rhythm is atrial flutter. And then we go down on our bottom one, we see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we're right at that RVR kind of setting, Rhythm looks quite regular. We also see that we have flutter waves here. PR interval is absent. So once again, you could argue atrial flutter to atrial flutter with RVR. Now let's move on to atrial fib. So that's one of the most common atrial dysrhythmias that you'll encounter. And it has three characteristics, and I'm going to ask you to definitely remember these three, as you see it, three definite characteristics, but we'll talk about them again in a second. And I'm just going to call them just the rules. So these three characteristics of A, you see absence of P waves. So in AFib, you don't see the normal P waves that represent atrial depolarization. Instead, they are completely absent. Those P waves are replaced by F waves or fib waves, fibrillatory waves. The normal P waves are replaced by these rapid, erratic electrical impulses in the atria, which create fibrillatory waves. So these waves appear as a chaotic, undulating baseline, indicating that the atria is fibrillating or quivering rather than contracting in a coordinated way. Then we also see that it's irregularly irregular, and that's within the ventricular response. So the ventricular response is totally irregular, meaning the time between each ventricular beat varies unpredictably. So this is often described as irregular irregularity, or just irregularly irregular, because there's no consistent pattern to how the impulses get through the AV node to the ventricles. So these characteristics make atrial fib easy to recognize on an EKG, and it's important to monitor the patient closely due to potential for RVR, so those rapid ventricular rates, and the increased risk of stroke or blood clots that's also associated with atrial fib. Now in atrial fib, the QRS complexes, typically within normal limits because the ventricles are still receiving those electrical impulses, even though they're coming from the atria in a chaotic and disorganized way. So this means that while the QRS complex might look normal in terms of width and shape, the rhythm itself isn't normal. And that the cause of this chaotic rhythm is that there are multiple ectopic foci areas in the atria that are firing off electrical impulses at an extremely fast rate. So these impulses are trying to stimulate the AV node to conduct them to the ventricles. However, the AV node can't handle all of these rapid impulses because it's being overwhelmed. So as a result, the AV node allows impulses to enter the conduction system at random. It just leads to that irregularly irregular ventricular response that we see in AFib. So this random conduction, it just creates this erratic and unpredictable rhythm of the heart, contributing to the absence of regular P waves and the irregular timing between each heartbeat. So atrial fib, we have an atrial rate of 350 to 400, ventricular is variable, the rhythm's irregularly irregular, no normal P waves are replaced by fibrillatory waves, so no discernible PR interval. So the main thing that we see when we look here, we can tell right away it's just erratic, there's no regularity. But our rate is 1, 2, 3, 4, 5, 6, 7, 8, 9. We see a rate of 90. We mentioned that the rhythm was irregular. We see no discernible P waves. We see that they're replaced by fibrillatory waves, no PR interval. So we should know that this is atrial fib. Now, this rhythm can be chronic in nature, and meaning it can persist over time, so it's commonly associated with several underlying heart conditions such as CHF or even rheumatic heart disease, hypoxia, MI, digitalis toxicity, electrolyte imbalances. So, when treating AFib, especially if the heart rate is too rapid, the goal is often to slow the heart rate to below 80 to 100 to help prevent complications like heart failure or stroke. Now, it's typically done with medications. We want to make sure that we're monitoring the patient's rhythm and vital signs to ensure the heart rate slows effectively without causing further issues. So treatment strategies can also involve rate control, rhythm control, or in some cases, procedures like cardioversion just to restore that normal rhythm. However, slowing the heart rate is often our first priority, especially in these patients with rapid AFib. Now here's what I was saying where I just kind of put this together. So when we look at this, when atrial fib, we talk about the ventricular response rate can vary, leading to different impacts on the heart's ability to perfuse the body. So in AFib with RVR, the ventricular rate's greater than 100. It's called rapid ventricular response, or RVR. So this causes the perfusion issues because there's a decreased ventricular filling time. So with the heart beating so fast, there's less time for the ventricles to fill properly. And then there's also a decreased atrial kick. So the atrias aren't contracting effectively, leading to a loss of the atrial contribution to ventricular filling. Typically accounts for, remember, 20 to 30% of the blood volume in the ventricles. So that means the heart is not pumping blood as efficiently, which can lead to symptoms of poor perfusion. So we can see dizziness, fatigue, hypotension. And then we see atrial fib with SVR, or slow ventricular response. So when the ventricle rate is less than 60, it's called slow ventricular response. So that might sound more manageable. Perfusion can still be compromised because of decreased cardiac output. So the slow rate can mean the heart isn't pumping efficiently enough to meet the body's demand for oxygen and nutrients. And then we talked about decreased cardiac output, so we would have a decreased heart rate, decreased stroke volume. So that low heart rate combined with the reduced stroke volume results in that lower cardiac output. Once again, just meaning the body's not going to receive enough blood. And then we see down here, we see the rules for AFib. We see no discernible P wave. So the P wave is completely absent due to chaotic activity in the atria. And then fibrillatory waves. So instead of the normal P wave, you see fibrillatory waves, which are small, irregular waves indicating that those atrias are quivering. And then it's irregularly irregular. So that ventricular rhythm is irregularly irregular, meaning there's no consistent pattern or interval between the heartbeats. So each one is just a different length. All right, supraventricular tachycardia rhythms. So that's just a general term used for all fast or tachy dysrhythmias. So where the heart rate is greater than 100. Now, this includes any tachycardic rhythm that originates above the ventricles, supraventricular, that should make sense, above the ventricles, meaning the problem is occurring in the atria or the AV node rather than in the ventricles themselves. Now, the term paroxysmal refers to the fact that the rhythm has a sudden onset and or cessation. So it means a tachycardia can start and stop abruptly, which is a key feature of many supraventricular arrhythmias. It often happens without warning and can last for a few seconds to several minutes or longer, and then they may resolve on their own and they may not. So supraventricular rhythms, this situation refers to ectopic atrial tachycardia, which occurs when a rapid ectopic focus in the atria overrides the SA node and takes over as the heart's primary pacemaker. So essentially, a single irritable site in the atria starts firing electrical impulses at a faster rate than the SA node, resulting in a fast heart rate. So that rhythm can look a lot like sinus tach at first glance because the QRS complexes are usually normal and the heart rate is elevated. However, the key difference is that sinus tach typically doesn't exceed 160 to 170 at its highest range, whereas ectopic atrial tachycardia can result in a heart rate that exceeds this range. So when we're talking about supraventricular tachycardias, that they typically exceed this range. So while the heart rate may be fast, it may resemble a sinus tach. The origin of the electrical impulses is different. So in sinus tach, the impulse comes from the SA node, but in supraventricular tachycardias or ectopic atrial tachycardia, they come from an ectopic atrial focus. So this is why the rhythm is considered abnormal, despite appearing similar to sinus tachycardia at times. So the main thing we're going to see here is just going to be the rate. So typically our atrial and ventricle rates are going to be matching, but we're going to be at a very high rate. So 150 to 250, the rhythm is regular. P waves usually not discernible, especially at the high rate range. I kind of mentioned that before. So the PR interval is not discernible. And typically the QRSs are quite narrow, just because it's happening so fast. So we see at the top, this is obviously a really fast one. Looks like we got about 25 here, so 250. looks quite regular. We don't see any P waves, no discernible P waves. So PR interval is going to be absent. That's quite narrow QRS, so supraventricular tachycardia. And then down here, we're looking at kind of the same thing. So we've got 1, 2, 3, 4, 17. So 170, it's regular, same thing. We don't notice a P wave. QRS is good, so we're looking at supraventricular tachycardia. Now, lots of causes can be triggered by several causes when we talk about supraventricular tachycardia. That includes overexertion, so physical activity that just really pushes that heart to work harder, so can sometimes trigger rapid atrial rhythms. Stress as well, hypoxia, so low oxygen levels can irritate the heart's tissue, and that leads to those abnormal electrical impulses. Excessive use of stimulants, so when you're on your third 24 and you're taking in lots of caffeine and nicotine and what other stimulants you might be using, that can increase the heart rate and potentially trigger an ectopic focus in the atria. Hypokalemia can do that, as well as just atherosclerotic heart disease as well. So treatment options. Treatment typically focuses on slowing the heart rate and then restoring the normal rhythm. So here's a few common approaches. So vagal maneuvers, typically when people aren't sick, this is the techniques that stimulate that vagus nerve, which releases acetylcholine, and then it slows down the heart rate. So a couple of common vagal maneuvers include like bearing down, coughing, squatting can do that, it increases vagal tone, or even a carotid sinus massage, which typically is not really recommended. However, it can do that. So these methods, they work by increasing parasympathetic tone, and that helps slow down the electrical conduction in the heart. Now, there's drug therapy as well. So if vagal maneuvers are not effective, medications may be used to help manage the rhythm. So commonly used drugs include adenosine, so that drug can quickly slow the heart rate by blocking the AV node temporarily, which can help terminate the tachycardia. And then we can get on to synchronized cardioversion. So if that rhythm is not responding to vagal maneuvers or drugs, synchronized cardioversion, so what we're saying is just really this real controlled electrical shock. It may be used to reset the heart and restore normal rhythm, especially if the patient is unstable. Not just especially, however, that should be unstable before we cardiovert them, or if they're experiencing significant symptoms. So treatment plan depends on the patient's stability and the underlying cause. Goal is always to restore the normal and stable rhythm and prevent complications. Okay, WPW, so Wolff-Parkinson-White syndrome. That's this condition that's characterized by an extra conduction pathway. It happens between the atria and the ventricles. So in WPW, there's an abnormal extra pathway, and that's known as the bundle of Kent. It allows electrical impulses to bypass the normal AV node and travel directly from the atria to the ventricles. So this additional pathway can lead to faster conduction and then premature ventricular stimulation. Now on the EKG, the most distinctive feature that we'll see of WPW is the delta wave. And what that is this slurred upstroke on the QRS complex. And that represents the time the impulse takes to travel down that extra pathway before being conducted through the normal bundle branches. So this causes this pre-excitation of the ventricles. Now, due to the extra conduction pathway, the QRS is wider than normal, typically greater than 0.10 seconds, because the electrical impulse is taking a longer route through the ventricles. So because that impulse is traveling through the bundle of Kent, in addition to the normal conduction system, the ventricles are stimulated earlier than they would be normally, which leads to that pre-excitation seen on the EKG. So really the big pieces that we're talking about here is you'll see a delta wave on the EKG. That's kind of that hallmark sign. And then the QRS is widened, like I said, typically greater than 0.10. Now that's due to that presence of that extra electrical pathway that leads to the abnormal conduction and then the pre-excitation of the ventricles. So patients with WPW may experience some tachyarrhythmias like SVT. So monitoring and treatment can include medications, It's things that they're going to do at the ER, catheter ablation, or other interventions that may be necessary. So here's what we're talking about with that delta wave. You see how it's not nice and tight. We don't return to our isoelectric line or a baseline, and then we get this slurred upstroke here. So this WPW, it's just this condition that affects the way electrical systems travel in the heart. So normally the heart beats in a very organized, rhythmic way, thanks to the electrical signals that travel along specific pathways. But in someone with WPW, there's that extra pathway that we said. It's kind of like a little shortcut, and it allows electrical signals to take a quicker route. So here's a good example of it as well. We see it with the little red arrows, obviously. But that's another good example. So clinical significance. So wandering atrial pacemaker, that's that rhythm where the pacemaker site shifts between the different locations in the atria, internodal pathways, or the AV node. So it's typically not clinically significant. The wandering atrial pacemaker is often benign, does not usually cause major symptoms or complications, often asymptomatic. Now, it can be a precursor for other atrial dysrhythmias. So while it's not usually dangerous, like I said, it can be a precursor or signal for the development of other more serious atrial dysrhythmias, things like atrial fib or atrial flutter. Rhythm can be triggered by several factors, one of which is digitalis toxicity. So where that medication digitalis that's used to treat heart failure, it becomes toxic at high levels. Other causes could include electrolytes, imbalances, heart disease, stress, or other factors that affect the heart's electrical system as well. PACs, remember that's that early beat originates from an ectopic pacemaker site in the atria outside of the normal SA node. So isolated PACs, not significant. If you see an isolated PAC on the EKG, meaning they happen occasionally, usually benign, not clinically significant, typically don't really cause any problems. They can be corrected by identifying the underlying causes. So if they're happening more frequently or causing symptoms, the key to treatment is to figure out what's causing them. So often treating the underlying condition can help reduce the PACs. Now, frequent PACs, so more than 6 a minute, they may signify some underlying heart disease. So if you notice some frequent PACs, as I said, more than 6 a minute, they may suggest that there's an underlying issue, such as heart disease. Could be to problems like ischemia, hypertension, other conditions that stress the heart. Now, these can cause some other atrial dysrhythmias. So frequent PACs can set the stage for other atrial dysrhythmias. They may trigger atrial flutter or atrial fib in some cases because the frequent early beats may irritate the heart's electrical system and set off more chaotic rhythms. And then atrial flutter. We talked about that being atrial dysrhythmia. So that's when the atria contract rapidly and regularly, often at a rate of 250 to 350 beats a minute, but the ventricular rate depends on how many impulses are conducted through the AV node. So remember that everything's almost every time is related to the patient's condition. So atrial flutter can be related to the patient's underlying health condition. However, we want to relate these rhythms to our patient. So are they sick or are they not sick when we look at them? Meaning their blood pressure, are they complaining of chest pain, all of that. So it may be triggered by factors such as heart disease, hypertension, coronary artery disease, even some pulmonary conditions. Now the ventricular rate, when we talk about the ventricular rate, if the conduction through the AV node is normal and the atrial flutter is well controlled, so that ventricular rate can remain in normal speed around 60 to 100 beats. In this case, the patient may tolerate the rhythm quite well and it might not result in significant symptoms or complications. But when the ventricular rate is normal or slightly fast, but controlled, atrial flutter, as I said, can be well tolerated by the patient, so they may not even experience any symptoms, but the ventricular rate, when it becomes quite fast, so that uncontrolled conduction, when the AV node conducts impulses at a fast rate, so for example, like a 2-to-1 conduction ratio, meaning every 2 atrial impulses trigger 1 ventricular contraction, then the ventricular rate can be much faster. So 100 to 150 or even higher. This can lead to a decrease in cardiac output because the ventricles don't have enough time to fill properly before contracting, which can reduce the effectiveness of the heart's pumping action. Now, if the ventricular rate becomes too fast and uncontrolled, it can lead to symptoms like dizziness, weakness, shortness of breath, because we have that decrease in cardiac output like we talked about before. And then atrial flutter. So the goal here is about controlling the ventricle rate. Restore that normal rhythm if necessary, and here's how it can be addressed. So treatment to decrease the ventricular rate is if they're stable, so not showing signs of poor perfusion. Medications are typically used to slow down that ventricular rate. It can be beta blockers or even calcium channel blockers. So rate control is often the first step because it helps prevent complications like stroke and heart failure, ensures the heart doesn't pump too rapidly and inefficiently. Now, if they're unstable, might move on to some cardioversion. And then atrial fib, another common atrial dysrhythmia where the atria, remember, is in this chaotic electrical activity, and it causing a loss of effective contraction, so no coordinated P waves. Now, that can lead to rapid irregular ventricular response, and the focus of treatment largely depends on the rate and then the stability of the patient. So with controlled atrial fib, there's really no immediate treatment there. We're just going to monitor them. Rapid atrial fib, so when we start talking about RVR or greater than 100, the primary treatment goal is to slow the ventricular rate to prevent the decreased cardiac output. So if the patient is stable without symptoms like dizziness, weakness, hypotension, meds like beta blockers or calcium channel blockers, maybe amiodarone, all of these depend upon your protocols, can be used. If the patient's unstable, meaning they're symptomatic, so we're thinking about hypotension, chest pain, altered mental status, cardioversion, either pharmacologic or electrical may be needed to restore the heart to normal rhythm. Now, there are some risks to atrial fib for these people because we talked about that results with a loss of atrial kick, that small amount of extra blood volume that the atria usually pushes into the ventricles before the ventricular contraction. So that loss of atrial contraction can cause a reduction in cardiac output, making the body less efficient at circulating blood. And then remember, supraventricular tachycardias refers to that group of fast heart rhythms that originate above the ventricles, typically from the atria or the AV node. So kind of the nature of these, they can occur in healthy individuals, particularly in younger people, and sometimes be well tolerated for short periods. For the others, it can be quite uncomfortable, lead to symptoms like palpitations, dizziness, even chest pain. Many people will describe it as their heart's racing, or it feels like it's running away from them. So when we talk about if they're symptomatic, so patients may report feeling their heart pounding or fluttering as the heart rate often significantly elevated, sometimes above 150. There can be dizziness and shortness of breath and chest pain. As you can imagine, with the heart rate that fast, probably losing a little bit of cardiac output. We mentioned vagal maneuvers, we mentioned some drug therapy, getting up to synchronized cardioversion. So let's take a look at a couple of rhythms. So when we look at this, we look at our rate, we've got a rate of 50, so we're a little bit slow. We look at our P waves, we see we've got completely different P waves. So we're probably going to call this wandering atrial pacemaker. Look at one more, and then we'll let you guys do those others. So 1, 2, 3, 4, 5, 6, 7, 8, rate of about 80. We don't see a discernible P wave. Rhythm looks quite regular, but we do see these flutter waves, 1, 2, 3, 4. So we have atrial flutter with a 4-to-1 conduction. And that's going to be it for us. That's 50 minutes. So if you made it through the end, I'm proud of you. But we'll see you soon.